Well, good evening, friends. Today, our guest speaker is Dr. Alison Moliterno from Johns Hopkins. She will be lecturing us on thrombosis in myeloproliferative neoplasm. This webinar is brought to you by Mumbai Hematology Group, supported by Novartis and managed by Perfect Square. I thank Lekha VK, Rahul Deshpande and the team from Novartis, Yash Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group, our guest speaker, Dr. Alison from Johns Hopkins, all our discussants who are eminent hematologists and medical oncologists from India, and you participants for sparing your Saturday evening if you are from India, and morning or afternoon if you are from the other parts of the world. Today we have registrations from almost 27 countries across the globe. Tomorrow morning at 11:30 a.m. IST, we have Dr. Barnali Das. She is a biochemist and immunologist from the lab medicine at Kokila-Bain, and she's going to speak to us on harmonization of biomarker reports in monoclonal gammopathies. Our discussants are very important personalities, and they have been all displayed here alphabetically. I'll just briefly introduce them to you. Dr. Ashish Dikshit from Manipal Hospital, Bangalore. Dr. Damodar Das from Guwahati Medical College, Guwahati. Dr. Dinesh Sheth from Mangalore Institute of Oncology, Mangaluru. Dr. Gopinathan M from MGM Healthcare, Chennai. Dr. Kripa Bajaj from Indo-American Cancer Hospital. Dr. Mahesh from Sparsh Hospital, Bangalore. Dr. Pujitha Baireddy from from Care Hospitals, Hyderabad. Dr. Radhika KK from Nizams, Hyderabad. Dr. Rupam Deka from AIMS, Guwahati. Dr. Gundeti from Nizams, Hyderabad. Dr. Sanjukta Roy from St. John's, Bangalore. Dr. Satish Kumar from Manipal Hospital, Bangalore. Dr. Shilpa Prabhu from Majumdar Shah Medical Center, Bangalore. Dr. Shrikant M from Apollo Hospital, Chennai. And Dr. Tejaswini from Majumdar Shah Medical Center, Bangalore. It's time to introduce our guest speaker, Dr. Alison Moliterno. I understand that she has retired in February this year and joined Food and Drug Administration, US. Until then, she was Associate Professor of Medicine, Hematology Division, Department of Medicine, Johns Hopkins. She completed her internal medicine training at Johns Hopkins and pursued her Hematology Clinical and Research Fellowships at Johns Hopkins University School of Medicine and Johns Hopkins Hospital. In 1998, she was awarded a prestigious Doris Duke Clinical Scientist Award and joined the Johns Hopkins faculty. And since then, she has been directing numerous basic and translational projects in blood diseases. Her major clinical research involves the study of chronic myeloproliferative neoplasms. Her research has focused on the genetic and epigenetic lesions associated with MPN with the goal of improving diagnosis and treatment of these disorders. Her work on the thrombosis and various determinants in MPN is all exhibited across the publications and her lectures, including at ASH. Today, she will tell us all about this thrombosis and myeloproliferative neoplasms. Over to Dr. Alison.
All right. So do I go ahead and share screen now?
Yes, please.
And I hope this is correct.
Yes.
All right. Thank you, Dr. Agarwal, and thank you to this really wonderful, amazing opportunity to speak to so many of my colleagues and wonderful people across the globe. I decided on my title, JAK2 V617F VAF, or variant allele fraction, and we'll discuss the thrombotic risks, mechanisms, and management, and specifically within polycythemia vera. Okay. Yes, I would like to disclose that in the last 5 years, I've done advisory board participation for 2 companies, Pharmacentia and Protagonist. And as Dr. Agarwal said, I have moved on from a full-time academic position to be a medical officer in our U.S. Food and Drug Administration as of just a few months ago in the Center for Drug Evaluation and Research in the Division of Non-Malignant Hematology. So my objectives today are to review JAK2 V617F and the variant allele fraction, and as it determines the quantity of blood cells in polycythemia vera, to review its reflects on thrombotic disease burden and disease progression risks in PV, and also to review that clonal suppression of the JAK2 mutated stem cell addresses myelosuppression, thrombosis risk, and disease progression in PV. But we're all clinicians here, and so I want to start off my presentation with a case that was referred to me in my clinic just a few years back. And this gets to the latency of JAK2 V617F associated cytoses and also thrombotic risk. So my patient is now in his mid-80s, but a couple of years ago at the age of 79, he was traveling in France. He tripped, broke his ankle, and suffered a deep venous thrombosis. Came back to the United States and saw a vascular specialist. And in 2018, his deep venous thrombosis was being treated. He was doing fine, but the vascular specialist noticed his hematology was unusual. He had a thrombocytosis and a slight elevation in hemoglobin. That was when he was referred to me, and by 2020, he fulfilled the WHO diagnostic criteria for polycythemia vera with this hematology here, with hemoglobin above the threshold or hematocrit, a panmyelosis. He had a bone marrow biopsy, which showed typical features of myeloproliferative disease with hypercellularity, and he was indeed JAK2 positive. But in looking back, he was followed at the Johns Hopkins Hospital in various clinics for years, and you can see these problems just didn't start in 2018 in terms of his hematologic abnormalities. So you can see the thrombocytosis developing nearly 10 years documented before this event. And so you can see that latency. And then another important feature was that he had actually suffered a pulmonary embolism in 2014. This was after he had a radical prostatectomy for prostate cancer. This was post-operative, and so again, it was deemed to be related to the procedure. But you can see at this time, he also had evidence of his MPN, and so potentially another reason for the hypercoagulable risk. And we detailed this case for ASH a few years back. So I just want to digress a little bit. Many of us in the audience have lived through the first 100 years of polycythemia vera, not all of those 100 years. But since I'm from Baltimore, I always have to include Baltimore. Baltimore is the center of everything in terms of hematology research. That's at least how we think here, which I know is pretty provincial. But we do claim William Osler, who was the first chief of medicine at our hospital. And in 1903, he was not the first to describe polycythemia vera. That was Vaquez several years before, but he was the first to describe cases and present them in national meetings. And then when he was writing his principles and practices of internal medicine, the first sort of textbook of medicine, he included polycythemia vera as a new entity. And he actually coined the phrase polycythemia vera. So again, in 1903, and then over the next 100 years, we had major signposts of understanding this entity. Osler described this in a few patients, and then within 20 years, there were several hundred patients described in the literature of this entity. But of course, at that time, we didn't really know much about blood physiology. In 1948, the term erythropoietin was coined, and and by 1951, William Damashek, who was father of hematology in the United States, of modern hematology, coined the phrase myeloproliferative disorders. This was a group of disorders that shared a lot of features. Too many cell production, tended to have low erythropoietin levels, and that there was an intrinsic defect within the cell that made it grow more than normal. A major event in the 70s was this demonstration of endogenous erythroid colonies. And here's a picture from Perkal's paper showing this. Again, normal stem cells without erythropoietin didn't really make those nice red hemoglobinized bursts. But in polycythemia vera patients, they grew beautifully without erythropoietin. Again, this growth factor independence that was such a key feature of the disease. In 1985, the BCR-ABL oncogene was cloned, and really CML pulled away molecularly from the other myeloproliferative neoplasms in its unique features that was very separate from what polycythemia vera was. To understand the driver, you need to know about the gene itself. And in 1998, the JAK2 gene itself was cloned. And it was actually cloned as part of a rearrangement TEL-JAK2, which was a constitutively active oncogene. So that's how its entity was first identified, but was quickly realized that this was a growth factor receptor, a signal transduction agent. And then finally in 2005, the French really had identified JAK2 V617, the acquired somatic point mutation that causes polycythemia vera. And that was really the major signposts. And we'll get back to that. So many long latency of understanding the biologic differences of a polycythemia vera stem cell, but then the unique clonal driver in this century. So again, back to 2005, we have the discovery in PV, and in that year, the JAK2 mutation was shown to be an acquired event. So again, never a germline transmission, occurred in a hematopoietic stem cell, and a very long-lived stem cell, but it not only intersected or was very prevalent in polycythemia vera phenotypes, but also essential thrombocytosis, primary myelofibrosis, and even refractory anemia with ring sideroblasts and thrombocytosis. So what I have here is a Venn diagram. So if you could imagine all of the JAK2 positive individuals, that's in the red here. And again, within that, polycythemia vera is the most common blood disease associated with JAK2. Very little are outside of the JAK2 V617F realm, as you can see here, and those are usually mutations in a different exon of JAK2. And then about half of essential thrombocytosis patients carry the JAK2 mutation, and at roughly 60% of primary myelofibrosis and refractory anemia with ring sideroblasts and thrombocytosis. So you can see there's a lot of overlap, and very puzzling. Why is that? And also I've overlaid these from each other because we know many patients with ET, or a high platelet count that's JAK2 positive, can evolve into polycythemia vera. Like our case that I just mentioned, our patient probably evolved. And similarly, we have many patients with polycythemia vera who evolve into primary myelofibrosis. So this sort of spectrum of diseases. But we know, like, how do we know that JAK2 causes, JAK2 V617F causes any of these entities? Well, we know this because the mutations recapitulate human disease in a mouse. So if you put the driver, like the CML, BCR-ABL, into a mouse model, that will recapitulate all the human features of disease. But a big difference with JAK2 is that the genomic burden modifies the presentation and evolution. So we'll get to this a little bit, but how much JAK2 you have seems to determine whether you have ET, PV, or myelofibrosis phenotype. And that's true in both the human disease and also in mouse models. The more JAK2 you put in, the more of a PV phenotype, and then even more JAK2 you express, then you tend to develop a fibrosis phenotype. Yes. So as I mentioned, the mutations recapitulate disease. How much JAK2 you have recapitulates the human disease. And so I have this model here that the JAK2 mutation occurs. It's an acquired event in a hematopoietic stem cell, leads to overproduction of cells. And then all of us, right, we see these blood counts every day in our practice, where pretty much the whole hemogram here is abnormal in a PV phenotype. So again, while we often are talking about the red cells as a defining feature, too many red cells, it is a panmyelosis with neutrophilia and thrombocytosis. Now, like our patient, there's a lot of latency with JAK2-associated cytoses. So after the JAK2 mutation was cloned, we could look back and find that, yes, most people who had the disease had the JAK2 mutation, and in isolated cases where you could find an old stored sample, say of someone who potentially donated bone marrow for a stem cell transplant, and then 10 years later developed themselves polycythemia vera, that in that additional sample, old sample, that you could find evidence of JAK2 V617F. So it occurs in a stem cell, but it now we understand it takes years for the number of mutated stem cells to really accumulate enough so that you have a phenotype presentation. So again, it occurs 10 years ago, 20 years ago, but we're not seeing the full effect on the hematology maybe until 25 years. And several groups have now published on this by doing whole genome sequencing of multiple stem cells from P-Vera or ET patients with JAK2 V617F, and they can define that the mutational event occurred so many years early, sometimes at the age of 9, when the patient presents at the age of 50 with their myeloproliferative disorder. So this understanding this helps us understand that while we may not recognize the disease until year 25, the risk associated with JAK2 V617F, whatever those risks are, has been present now for years before. Like our patient who had his first pulmonary embolism years before his diagnosis. So now I'd like to move over, and after the 2005 discovery, in 2007, it became very clear that, again, this amount, and we're now going to refer to this as the variant allele fraction, within the MPN in general, but within PV particularly, really has significance or biological meaning. And how do we get variant allele fractions? So what I have in this cartoon is on this column here is the calculated variant allele fraction by percentage. So that's the percentage of alleles in the cells displayed that have the JAK2 mutation over the total number of JAK2 alleles, wild type and mutated. In a stem cell that does not have JAK2 V617F, that's in white here or light gray, and that VAF would be 0. There's no mutation. In this circumstance, there's one blue cell, and blue means that it's an acquired mutation of JAK2 V617F in one allele. So in this cell, 50% of the alleles are V617F or VAF, but now we have 2 other cells that are wild type. So if you add this up, the VAF of this total population would be 17%. Now, in next row, we now have a red cell, and this is a unique feature of JAK2, of activating mutations of JAK2, of the JAK2 gene. This is highly associated with this event called uniparental disomy, or mitotic recombination event, where you go from 1 copy of the mutation to 2 copies, or homozygous. And this happens very frequently with activating mutations of JAK2 in every circumstance, but particularly with V617F. So a high probability that you are going to become homozygous. Now, if you have 2 copies here and 4 negative cells, that variant allele fraction for the whole group will be 32%. And by plucking and looking at different clones, which many of us have done over the years, we can see that within a patient's bone marrow, they may have 100% JAK2, meaning that every cell that is operating has 2 copies, but it's almost a continuous variation back over time or across different patients, because of these cells coexist with each other in the bone marrow compartment. So every patient who has JAK2 V617F will have residual wild types, heterozygous or homozygous JAK2 cells in polycythemia vera for sure. So this was recognized back in soon after the initial reports, and now translating this to clinical phenotype. So what I have shown here is from the group in Denmark, Larsen, showing again the VAF or JAK2 V617 percentage, again done either from bone marrow or peripheral blood, and then categorized on the y-axis here is the VAF, and then different disease groups. And you can see between ET, PV, and primary myelofibrosis, there's significant differences between the VAF measured, and you can see that there still is quite a bit of overlap, but ET generally has the lowest amount of JAK2. PV of huge dynamic range, as you can see here. And then primary myelofibrosis tends to have the highest. And this really didn't matter whether you looked at the total population at whatever time point or of the newly diagnosed. Again, we have just a huge range of VAF in newly diagnosed PV patients. How does this translate into blood counts in the rest of the phenotype? So again, within 2007, Alessandro Vanucci, who was published so widely on VAF, Larson, and then the Italian Francisco Passamonte, really did beautiful studies looking at dividing up allele burden now within PV, not the MPN total, and just showing that the more JAK2 VAF you have, the higher the white cell count, the higher the neutrophil count, as you can see. Platelets actually tend to fall as the higher VAF you have. And then a measure of cell turnover or hypoxia, whatever we think the serum lactate dehydrogenase represents. You can see this also tended to climb across the bins of low, medium, and high JAK2 VAFs within PV. And these were done in several hundred patients, and these are all different groups reporting. So this is a pretty solid finding. I just wanted to show you again this, as I mentioned, the VAF is now a continuous variable, right? Before I showed in just quartiles. But now if you take on the x-axis, the VAF as a continuous variable and then plot hematocrit, total white cell count, even platelet count and mean corpuscular volume, you see these very highly significant correlations. So again, and these are individuals at their diagnosis of polycythemia vera. So again, very strong correlations. And interestingly, as I mentioned, platelet count tends to reduce the higher VAF you have within P-vera. And mean corpuscular volume, also, these are not patients who were phlebotomized. This is just how they presented. And so you can see this, the more VAF you have with JAK2, lower the MCV. And then the same for LDH and leukocyte alkaline phosphatase. Again, these were all other markers highly correlated. And more from Dr. Vanucci's other systemic symptoms, such as pruritus. Again, the relative risk of pruritus very strongly correlated with higher VAF. Systemic symptoms to some extent. Splenomegaly for sure. And again, these were at diagnosis. And then very large spleens, again, very high hazard ratio. And then for this group, because we are going to get to thrombosis, I promise, but again, they looked at this a couple hundred patients, and then again, we have total thromboses and association with VAF. The thrombosis at diagnosis, maybe not so much, but in follow-up, again, these very high allele burdens are above 50% seem to supply a signal. Now, I also want to, this is a beautiful study by Masla just last year, looking at a group that actually was doing red cell masses. So again, on those red cell mass, which we really can't do here anymore. But again, a good diagnostic tool, you can see this very tight association with JAK2 VAF. Again, how much more you have, how means the higher blood volume. And again, the erythropoietin level, which tends to be low in P-vera, but again, higher red cell mass and the lower erythropoietin level. So again, the red cell mass is really a measure of clonal expansion of the stem cell and this overworking of total blood volume. More recently, getting a little more refined picture about the risk for thrombosis in MPN. This was a study, again, just published last year that really looked at several, a couple hundred patients, and it did a nice cumulative study and divided JAK2 less than 50% versus greater than 50%. And these, again, were primarily P-vera patients. And you can see that, again, if your JAK2 allele variant allele fraction was greater than 50%, you had a significant higher rate of venous thromboses. But interesting, when they divided it to arterial, there was lost significance. So very important that maybe the venous signal is driven by JAK2 V617F or the blood volume. And then finally, a very nice study from China looking at a very large number of patients. And again, these were all JAK2 V617F positive. They were a bin of MPN, but again, most of these patients were polycythemia vera. And they did a really nice multivariate analysis looking at independent factors. And again, in the MPN, of course, age is always a risk for thrombotic events. Prior event, as all of us know in thrombosis research, that's always significant for future events. Hematocrit greater than 48% at presentation. And then history of thrombosis and JAK2 V617F greater than 50% maintained independent significance for thromboses there. So again, within PV, they note, and here it's a little different. 90% of the events were arterial. Most of the subjects had PV. And again, within PV, the very strong signal of greater than 50%. So they mention here, therefore, reducing JAK2 during treatment is crucial to prevent thrombosis, especially the occurrence of arterial thrombosis complications. So that's a bold statement because, right, we're making associations. Does association really drive causation? And again, will lowering VAF alter thrombosis risk? That remains to be seen. I now want to move away from thrombosis and just talk about clonal expansion in VAF. And by now clonal expansion, I mean development of splenomegaly. Again, splenomegaly is a feature of extramedullary hematopoiesis and is driven, you can see again, by the risk of developing splenomegaly is so much higher if your JAK2 allele burden is greater than 50%. So within the first 10 years of diagnosis, you can see almost 20% of patients who presented with a VAF of greater than 50% have developed significant splenomegaly, whereas this does not occur in the individuals with maintaining a low JAK2 mutant allele burden. So very important for us as we try to predict the future for our patients. Where are they going to go with polycythemia? Will they have a more indolent course or be plagued by extramedullary disease? So I want to sum up this section by talking about the clonal expansion as shown in this cartoon, and then the association. So the myeloproliferative pathway, of course, the consequences of higher VAF are more cytoses with the exception of platelet count, and seemingly a thrombotic risk. Again, is the thrombotic risk really driven by the number of cells themselves? That's a question, or other features. Certainly the bone marrow niche, so the more JAK2 signaling you have, these very high levels, absolutely associated with extramedullary hematopoiesis, fibrosis, stem cell mobilization, and neoangiogenesis within bone marrow. We know that inflammatory cytokines are, again, the higher VAF you have, the more of these inflammatory cytokines that are released. And the consequences of that are both on the niche and also genomic instability. And then finally, we know that JAK2 V617F is present both in the stem cell and the peripheral blood as a measurement. And higher stem cell levels particularly are important. So I just want to digress a little bit now about what else was going on in thrombotic risk studies in the MPN. As I mentioned, right back to 2005, well, certainly the discovery and association of disease. And within that same year, the British looked at one of their very old studies, the PT1 study, which was a thrombosis risk study in ET and PV, and opened the freezers and re-genotyped everyone. And if you were JAK2 positive versus negative, your thrombosis risk was much higher. By 2011-13, the CalR discovery, again, looking at ET patients with their CalR versus JAK2 positivity in more than 1,000 individuals. And again, having JAK2 really increases thrombosis risk more than CalR mutation. This JAK2 status was added to the IPSET thrombosis scoring system in 2014. And then there was a beautiful paper looking at the lifetime thrombosis risk in PV and MPN in 9,000 individuals from Sweden. And again, looking at the MPN in general, most of them, again, too, that the arterial thrombosis risk was similar to smoking that and the venous thrombosis risk was similar to being a factor V Leiden carrier over the lifetime of these 9,000 patients. And then finally, the studies that I've mentioned more recently, the JAK2 V617 greater than 50% seems to really pose a specific thrombosis risk in PV. But so this is a cumulative now 13,000 MPN wide study over these years. These are rare diseases, so we get excited when we start to see such large numbers because we really get a lot of power can make these associations. But what I also want to draw your attention to, and you're all aware of it, I know, is that clonal hematopoiesis at the same time has been recognized as a vascular risk factor, and JAK2 V617F is about the 4th or 5th most common clonal hematopoiesis lesion in the general population. So again, my prior slide was 13,000. Now this represents 173,000 individuals. So again, going back to 2005, in 2007, the JAK2 discovery, there was a study looking at 3,000 individuals in China going to general medical clinics, and they just genotyped for JAK2 V617F in these 3,000 individuals. They weren't coming to the hematology clinics, they were just coming to clinic. And they found that 0.1%, I believe, tested positive at very low levels. And I remember reading this article in Blood thinking, well, why would they even do that? But they had a lot of foresight to do this. Other studies started showing this, and this Danish population, again, looking at unselected individuals, most in midlife, and looking for JAK2 V617F found a very identical statistic, about 0.1%. Carried JAK2 V617F. They were not hematology patients, not diagnosed, but certainly there was a risk for developing MPN over the next few years, mortality risk and cancer risk associated with being a carrier state. And now over the last 10 years, this has been replicated in many population studies across the world. And having a JAK2 carrier state or clonal hematopoiesis less than 2% or 1% is definitely associated with thrombosis risk, heart disease risk, and now more recently stroke and VTE risk. And I'll just show you a couple of this one patient from Cordura. This was published in 2019. They looked at both JAK2 V617F and CALR mutations in the general population. So this was the suburban Danish population. And again, they just 20,000 individuals, they genotyped for JAK2 V617F using a very sensitive assay that could get, I think, to below 0.08%. And they also had a CALR assay looking for this. I won't talk about the CALR mutation prevalence within JAK2. You can see 19,000 were 0 or negative for JAK2 V617F, and they're represented in this bin here. About 500 or so were JAK2 V617F clonal hematopoiesis positive, and they had allele burdens less than 1%. And then another 116 were JAK2 V617F positive, greater than 1%. So here's just the relative number of individuals. Above here, they happily were able to, sorry, phone, look at their coexistent CBCs at the same time. And you can see that as the JAK2 chip increased, you can see significant increases in white cell count, hemoglobin, and even platelet count over these groups. And then finally, there of these 20,000 individuals, there were 16 of this group who actually had a diagnosis of MPN. And so they're represented here, and their allele burdens were between 2 and 100, and they were all groups ET, PV, and myelofibrosis. So their blood counts kind of reflect that MPN status, and whether they're treated or not, we don't have information. But what's very important at these low levels was then looking at the thrombosis risk. And this is one of these studies where they've been following these patients. They can look into their records and look for events. And so they quantified VTE events and hazard ratios, basically, or thrombosis odds ratio, and stroke, ICVD. And you can see at the normal, compared to the normal population or JAK2 negative population, again, if you're less than 1%, while your blood counts are adjusted up slightly, no increased risk, but again, a little bit of JAK2 greater than or equal to 1%. Now you did have a VTE risk, odds ratio of about 3 compared to JAK2 negative. Still no signal with stroke risk. And then in the MPN population, again, you can see there, VTE risk about almost 6-fold higher and stroke risk now about 3-fold higher. So this gives us very good information about, again, amount of JAK2, how it affects the blood counts, and whether blood counts associate with thrombotic risk and to what extent this is. I just wanted to touch on some of these population studies. I mentioned the Danish suburban population, but these are the publications from the Copenhagen heart studies. They had a heart study of 10,000, general population of 49,000, and then their Danish suburban population of 19,000. Depending on the sensitivity of the assay used, again, the prevalence of carrier state or clonal hematopoiesis for JAK2, 0.2%, 0.1%, 0.2, and then in this very sensitive test from the Danish suburban population I just showed you, that was 3.1%. But the associations, again, who is the carrier? Increasing age, male sex, cumulative smoking. The associations are also higher death rates of any cause, any cancer risk, and hematologic cancer for sure. And then if you power the study big enough, right, you can start to see the signal for ischemic heart disease and VTE. All right, one of my fellows, Hannah Kaiser, has been working on a JAK2 meta-analysis and again, looking for published studies in addition to these, and presented this at ASH a couple of years ago, and we're almost ready to submit. But I just, again, looking through the literature for studies examining JAK2 carrier state or clonal hematopoiesis. And we came down to looking at 14 general population studies and 91 vascular disease studies. And just interesting looking at, again, now these studies, these are in thrombosis cohorts. So again, these weren't MPN cohorts, they were just thrombosis risk populations that were collected, and the number of studies, and then their prevalence in the thrombosis cases. So again, if we, and many of them had control groups, non-thrombosis control groups, and you can see the control groups, depending on how large they are and how sensitive the assay, some of them had similar JAK2 prevalence in the general population as what I just showed you. In the thrombosis cases, right, so splanchnic vein thrombosis, very high prevalence of JAK2 V617. I'm sure you've all on your consults seen individuals with Budd-Chiari, and we know that there's very high prevalence of having JAK2 V617F as the cause. But in other cohorts, multiple thromboses, again, 3%, so much higher than a control population. Cerebral venous thrombosis, again, a very MPN smelly type of presentation. And then DVT, PE, coronary disease, stroke, and PAD, peripheral arterial disease populations. So again, taking this all together of these 77 studies and thousands of patients, you can see if you look again for JAK2 associates in thrombosis cohorts. Many people will say, well, many of these people probably had MPN, and it's true, some of them certainly might, but many of them are latent, like the patient I presented, or not diagnosed. So you can see this effect. So, questions that come up about the clonal hematopoiesis in thrombosis is, are JAK2 carriers? Are they really a form fruste of PV, or are they just undiagnosed? What are the implications on blood counts, and what are associated clinical risks? And I think this is still to be determined. But within PV, I just want to get back to this, and we were able to publish this article recently in Blood, JAK2 allele burden and PVERA burden of proof. And again, we just compared and contrasted within PV, just using this categorical VAF, less than 50% or greater than 50%, the associations, and contrasting this with the clonal hematopoiesis groups where we're less than 1% or greater than 1% VAF. And you can see the directions are in the similar, right? The venous thrombosis risk, the more JAK2 you have in PV, it's about threefold. And very interesting, in clonal hematopoiesis, you have this same odds ratio risk. Other things, so C-reactive protein, again, very important, the more JAK2 you have. And again, we don't know if that's cause or consequence of having more JAK2 burden, but fascinating if that's present even at these very low levels, these significant differences in C-reactive protein, again, suggesting this additional inflammatory state. So the mechanisms of, well, why, what's going on in the stem cell and in the circulating cell to drive both the myeloproliferative phenotype and also the thrombotic risk that we've been talking about. So I will touch on some. This is, again, our diagram. JAK2 transmits, right? Here's it's sitting in the cells, the mutation, but the protein, the JAK2 protein, is a signal transducer. It transduces growth cell and sets up many growth pathways, but also reactive oxygen species and HIF signaling. So it's very much responsible for growth, but also glycolysis, cell renewal, has effects on iron metabolism, and then these other processes that we talked about. There's definitely HIF, or hypoxia-inducible factor upregulation with JAK2, and that the consequences of that are neoplastic growth and thrombosis risk. So HIF upregulation turns on many thrombosis risk genes. Neutrophil tissue factor, again, so JAK2 seems to drive up tissue factor in neutrophils, not only the number, but the quality. And this is associated with this NETs, microvascular thrombosis. We know that there's hepcidin deficiency within the JAK2 milieu. And again, this increases iron into the erythron. And as I mentioned, increased reactive oxygen species driven by this sort of hyper signaling. And that is associated with cellular aging, inflammation, and genomic instability. We talked a little bit about the inflammatory pathways, and we are all familiar with inflammatory pathways pushing venous and arterial thrombosis risk. Bringing everything together, when we think about PVERA, we think about the blood count, so quantitative changes. We think about the qualitative changes in the JAK2 bearing cells. Some other associations with allele burden here, and then clonal manifestations of clonal expansion. So splenomegaly, prevalence, the red cell mass, the number of circulating stem cells or CD34 cells, again, very highly associated with the burden. And then the 15-year myelofibrosis-free survival, again, if you have low allele burdens versus much higher allele burdens. So knowing the VAF is very important to understand the disease, understand mechanisms, and also prognosis for our patients. This is a study we did many years ago now. We looked in our cohort and had been using a quantitative assay. And this graph is just to show when we looked at patients prospectively over time or cross-sectionally, both showed us that JAK2 VAF with phlebotomy or hydroxyurea, sort of natural history, rises generally 1.4% per year in PV. There are slight differences between males and females. You can see there are some individuals who are at 30 years of their disease and they still have relatively low VAF, whereas others start off at a very high level. So again, not that everyone is going to rise, but the whole population seems to rise 1% per year. And we'll get back to that, but some prospective trials have really shown us this. So I just wanted to touch on these factors. We've talked about the discovery, and now we have targeted therapy and its role in treatment with ruxolitinib. And understanding and targeting clonal expansion, in the United States, we've had the ROPEG interferon approval just in 2021. And these agents all act at different parts of the stem cell pathway. So I just want to close on a couple important features about VAF in prospective randomized clinical trials with PV. So again, these are now the low PV and proud PV studies were ROPEG interferon. Low PV was done in Italy, proud PV in Europe and France. And again, this was just the age and disease duration. You can see these were relatively newly diagnosed individuals. They did not have thrombosis history in low PV or prior cytoreductive therapy. In proud PV, again, a little higher risk in that some had prior cytoreductive therapy, and you can see thrombosis rates at entry. In the response 1 and 2, these were the PV studies using ruxolitinib, randomized to ruxolitinib versus best available therapy. These were a much higher risk individuals, so they were older, they had their disease a lot longer, they all had to have prior cytoreductive therapy and splenomegaly in response 1. And thrombosis risk, you can see, was also fairly high, and white cell counts were higher. But I just want to draw your attention that look at the median JAK2 VAF for the studies. You can see lower risk VAF in these studies compared to the higher risk. And you can see this real progression of the meaning of VAF. Okay, now I mentioned in the prospective randomized trials using just hydroxyurea phlebotomy only in the treatment arms, they were able to measure VAF change over the first year and then over 5 years. And you can see with phlebotomy, hydroxyurea, or best available therapy, which was hydroxyurea or mostly, again, the VAF change over the first year was generally increased. In hydroxyurea, very interestingly, you get this immediate reduction over the first year, but by 5 years, it actually tends to climb and again, increase about 1% per year. In the ROPEG interferon, so ROPEG works to really disable the stem cell clone bearing JAK2 V617F, both in low PV and proud PV. The VAF change over the first year was -10 and -12, over 5 years -30, so that the average VAF at 5 years started at 42% and went down to 8%. And so what are that seems like this is working very differently. This is a graphic from Kalajian's 5-year follow-up or 6-year follow-up now of this group. And you can see the ROPEG interferon treatment VAF really starts to reduce and really come down, whereas the hydroxyurea comparator arm had this reduction, but then you can see it just bounces back. These are 3 other studies looking at either ROPEG interferon or other interferon alpha 2Bs and 2As. This is a composite of, again, these prospective trials. And again, they all seem to have the same reduction in VAF over the first 2 years. So this is not just a feature of the low PV or proud PV study, it's really a feature of interferon therapy. I also just want to mention that ruxolitinib treatment, so in response 1 and 2, now ruxolitinib is not thought to alter allele burden, or it certainly wasn't examined to do that. And I think they were really trying to show its clinical benefit, which they did, and not worry about allele burden so much, as this is really not targeted against the mutant allele. So in contrast to BCR-ABL and Gleevec. But I do want to draw your attention again in response 1 and 2, the ruxolitinib arms, again, they had VAF reductions over 5 years. So that again, starting at 56% down to 46% and 76% down to 47% average. So again, not as dramatic as with the ROPEG interferon here, but still quite meaningful. potentially meaningful. And studies now are looking at the individuals who had these great allele burden reductions. And you can see that they had marked improvement. These graphs aren't so easy to look at. But again, batch, you can see the baseline and just the increase over time in allele burden, and with ruxolitinib, the decrease in allele burden. And further studies looking at this, again, these are the waterfall plots of, or the plots of allele burden reduction. Huge variations with ruxolitinib, but still for some, there's actually quite a marked reduction. And that seems to have clinical consequences, and I'll just skip over these two trials. And what are the consequences? We know in the PROUD-PV study that when they used a composite endpoint, I mean, this is over the first 6 or 7 years now of PROUD-PV versus best available care in red, the patients do very well. These were recently diagnosed. So, but if you use a composite endpoint of disease progression, death, and thromboembolic events, you do better when your allele burden is reduced with ropeg interferon compared to best available care. And they noticed that depletion of JAK2 VAF to less than 1% at 6 years was achieved in 20% of these individuals. So that's really pretty remarkable, and more to come with the clinical associations with JAK2 reduction. So I just want to finish with some discussions about the therapies we have within polycythemia vera and the influence they have on quantity, quality, and clonal suppression. So we know that, yes, phlebotomy, you get rapid reduction of red cells in the blood volume, very important when we first diagnose patients. Hydroxyurea also gives good white cell, red cell, and platelet reduction. Ruxolitinib, though, in terms of control of blood counts, most reliable hematocrit control, so it gets 3 stars. Ropeg interferon, very great at controlling blood counts. However, it does take a little bit longer than ruxolitinib, so that's a disadvantage. In terms of quality of the cell, well, you know, phlebotomy, again, reinforces iron deficiency and tends to activate HIF through iron deficient mechanisms. And so there is always a concern that phlebotomy, you're not addressing the underlying problem, you're just taking off excess, but you may be exacerbating some issues with iron metabolism and thrombosis risk. Hydroxyurea may alter the quality of the cells, maybe reducing some of the activation, but it's not really targeted against JAK. And it does put a selective stress on the bone marrow HSC, and we have concerns about long-term with genomic instability. Ruxolitinib does reduce intracellular signaling. It does reduce neutrophil traps, and has other positive signaling effects. And then finally, ropeg, it may not do much immediately on the quality. It's not really anti-JAK2 signaling, but by targeting and extinguishing the JAK2 positive stem cells, it does quite a bit for the quality. And then finally, clonal suppression. I think this is really the way we need to think that this is an attainable feature. By clonal suppression, we mean reducing the stem cell burden and the VAF. Phlebotomy, we know VAF increases 1% a year. We know with hydroxyurea, there's a transient reduction, and then it rebounds. And then ruxolitinib, we're seeing mild to moderate, but highly variable VAF reduction. And then finally, with the ropeg interferon, consistent reduction in VAF, and this decreases to 1% per month over 36 months. Pretty reliable, decreases by 1%. So this is really something to consider when we're looking at our patients. Well, I just want to end that, you know, our challenge is about the quantity. Yes, we need to educate patients and doctors about the latency and dynamic nature of the disease. We're looking at several decades for our patients. So we need to do meaningful cytoreduction without toxicity, and also really start to embrace the role of VAF as a diagnostic and prognostic marker within PV. We need to understand the quality of the mechanisms how JAK2 alters cell function, and get a better understanding of methods of thrombosis and risk reduction, and design and use medications that really alter cell function and reduce thrombosis risk. And finally, this clonal expansion, we have to accept the gaps in our knowledge of the latent and dynamic disease due to this clonal nature, and examine both in the general population and our populations this latency and clonal expansion, and really come to make this a goal to address clonal expansion. I don't have time to, there are several papers coming out now showing that the more JAK2 allele burden reduction in PV in these prospective trials, the lower the thrombotic risk. I mentioned the PROUD PV study, but this is also now a signal coming up within the ruxolitinib therapy. So again, there is clinical benefit beyond count control with some of these agents. So I would just like to end and thank you so much. I have my two mentors, Jerry Spivak and Richard Silver, who have been convening a meeting in New York for 20 years about MPN, and have really helped me develop the program here at Hopkins. But our MPN mentors are all over the world, as you can see from these amazing studies, our research support. And, you know, for the last 20 years, I've done patient-centered research. And so I thank the MPN patients and families. Thank you.
Thank you, Dr. Allison, for that wonderful talk and giving us such insight into this subject. It was wonderful. It's really very heartening to see the progress that has occurred in this field. Before I open the discussion to others, may I ask you one very hypothetical question? Has a time come that we move from phlebotomy and hydroxyurea to ruxolitinib and interferon-based treatment for all patients of JAK positive conditions?
Yeah, I think that is my point. I would say in my, I'm going to stop sharing. I would say in my practice, you know, we have to do, particularly working for the FDA now, right? Do we have clear evidence of long-term safety and efficacy? I think there's certainly concerns about JAK inhibitors, long-term safety, and the interferons now also. Although we are gaining this wonderful information from these long-term and real-world studies. I was very heartened to see that my colleagues at the FDA here in the United States, that we approved ROPEG interferon for any patient, any PV patient, right? So regardless of risk or failed prior therapies. So really a nod that this is as safe and probably more effective than phlebotomy and certainly hydroxyurea. I recognize the problems with, you know, hydroxyurea is less expensive and available. And so, but I think when we're looking at a latency of so long and this knowledge that we really need to be addressing the disease on another level, it's hard to accept that. So I think it might have its place. Certainly phlebotomy has tried and true, but again, when we do prospective trials with phlebotomy, right, you can see its performance, and it really doesn't perform very well compared to these drugs. So now for all MPN, when you say for all MPN, ET and MF, I don't think we can say that, but certainly for polycythemia vera, I think we're looking at a new age.
Thank you. We have the raise hand sign. May I ask you one more question? Are there any studies looking at the combination of ruxolitinib and interferon?
Yes, there is, and there's one in I've forgotten the name. It's not the Dahlia study. I think it's called JUMP PV, and I think this is across not just PV, across MPN, and this is sort of problematic because once you say, let's just take all MPN together, you know, ET, PV, and MF, you have problems with signal, right? And I focus on the meaning of allele burden and JAK2 so much in PV because it's the cleanest signal. You know, ET, we don't understand why patients retained such low JAK2 levels and for so long. And MF, as you know, molecularly very diverse. But I would say that what I've seen from the combination ruxolitinib and interferon is, and it was in one of those graphs that I showed, that they had the same allele burden reduction. Safety was pretty good, and they hit their hematologic targets, improvement targets, or total remission faster than just ruxolitinib alone or interferon alone.
Thank you. So let's have our colleagues asking you a question now. Dr. Kripa, she is one of our brilliant researcher. She has very tough questions. So go ahead.
No, sir. So thanks, Dr. Allison, for wonderful talk. And just continuation to Dr. M.B. Agarwal's first question. So will your practice, like based on the treatment, will be based on the VAF? Will you select ruxolitinib patients having a high VAF? And second question is, if you do select certain things for the treatment, how do you follow the VAF, like for the further response assessment? How frequently will you assess VAF for the response?
Thank you so much. And it's a question we discuss constantly here. I've been very lucky here in Baltimore because about 10 years ago, I got our Johns Hopkins Genomics to do an in-house quantitative VAF that was fairly inexpensive. And so this was available to me clinically. I didn't have to get prior authorization from insurance. And so we've been using VAF from peripheral blood and have fairly easy access to it. When I meet new PV patients now, if there's really no contraindication, meaning a bad autoimmune disease or prior problems with an interferon, I actually suggest ROPEG interferon, independent of VAF. So whether patients are starting newly diagnosed and are at 20% versus 80%. So, and from the PROUD PV and now this Italian study called Low PV, I don't know if you've heard about this, but they just published their nice article in New England Journal Insight, but they used a fixed dose of 100 micrograms of ROPEG interferon in all comers, but it was a lower risk patient population and their VAFs were average 35%. But what I'm saying, the sum total of these is that the safety and efficacy is very good. And within a year, so I usually measure VAF at start, and then with interferons, I measure it usually after a year. You know, expect to see hopefully some reduction. And I have been seeing reductions about 1% per month that they're on, you know, so this is following what I've read about in the literature. I do this because one, if it's a subcutaneous shot, it's very tolerable. Patients give it to themselves at home every 2 weeks. Once you get hematologic control in PVERA, then you go to monthly dosing. And this is much easier than phlebotomy, checking your blood counts every month, and honestly easier to take than a pill. So if I meet someone that has a very high phlebotomy requirement, very high allele burden, and a very big spleen and symptoms, I will often start with ruxolitinib because you get better disease control and symptomatic control. And then sometimes I've switched them from ruxolitinib to ROPEG interferon after. I hope that answered your question.
Yes, yes, very much, Dr. Allison. And one more question. So where do you, which patients do you offer hydroxyurea? You clearly mentioned regarding phlebotomy, but which patients do you offer hydroxyurea in this point of time with all the evidence we have?
Yeah, I have to say I don't offer. So for newly diagnosed PVERA patients, I really don't offer it. I of course always have a dialogue with my patients, try to inform as best as we can. So many patients now and again, even in the elderly population, as we all get elderly too, like what is elderly anymore, right? But you know, even patients in their 80s, I started on Ropeg interferon. Reasons why is that, one, I've seen so many intolerable side effects from hydroxyurea in terms of skin changes and skin cancers, and this can really be a problem. So I you know, in rare patients who, what I really try to counsel them as best as we can, if their preference is to take hydroxyurea, then yes, after they've been informed. But yeah. Now, within ET, I think that's a different discussion, but I really want to limit discussion to PV. Can I ask you, how
Yes,
can I
yes,
ask
sir.
you, are you prescribing a lot of hydroxyurea?
No, I switched my practice to ruxolitinib. So
Mhm.
previously I used to practice, but right now I'm practicing ruxolitinib. It's like very much tolerated and easily available right now than
Yeah,
before.
yeah,
Yeah.
yeah.
And how frequently will you monitor VAF, madam?
I think most, you know, and again, yearly to every couple of years. Now that we have really disease-modifying therapy with Ropeg, I think it's no reason to measure more frequently than yearly. It is helpful to know if they're not getting a VAF reduction, or if their VAF went from 40% to 60% over a couple of years on whatever therapy that we're using. That is actually very important to know, you know, because you really can't tell from blood counts often, right? And so I use it two ways. One, to hopefully see this reduction, and two, to understand if it really is climbing despite ruxolitinib or even Ropeg. So I use it to examine both sides of it. But I don't think we need more than yearly. As we know, everything is on a 5 to 10 to 20 year time course here.
Thanks, Dr. Elsa, for answering my questions.
Thank you, Dr. Kripa. Before we go to Dr. Pujita, one question we'll take from the chat box. Now, where does all this leave us about aspirin and anticoagulants?
Yes, yeah. Yeah, so really terrific questions. And in the more recent studies, right, with Ropeg and ruxolitinib, you know, has aspirin been used? We'll first take the aspirin question. How effective is aspirin at preventing thrombosis risk? Well, certainly for venous thrombosis risk, all of us as hematologists, I don't know where we come out on aspirin preventing venous thrombosis risk. Do many of you believe that it does anything? I know we don't have orthopedic surgeons in the in the group. Some of them still believe it, right? But so I knowing that, and then if my patients have coronary artery disease, well, certainly I'll be using aspirin as secondary prevention, or you know, or an antiplatelet agent of another variety, certainly. But as truly, you know, I don't think it's particularly helpful in the JAK2 context. Now, the anticoagulants, absolutely. I think, you know, if you have, I now look at JAK2 as it's a fixed venous thrombosis risk factor. It's about, if you haven't had a thrombotic event, it's probably on the level of factor V Leiden carrier state. So again, everyone doesn't need to be on prophylaxis for sure, but certainly if you've had a prior event, yes, you stay on. And I'm now facing, well, what about my patients who had a prior event, but are on, say, Ropeg interferon, and their allele burdens really come down? Would I have the temerity to stop their anticoagulation? I'm still not there yet, to be honest. There has been some nice studies showing that DOACs are just as effective and safe these are real world studies, as opposed to warfarin for treatment of VTE.
So then there were these questions about whether now DOACs are good enough, or you still have to give vitamin K antagonists, and other questions are related to DOACs and aspirin together. Are they safe enough?
Yeah, so I will definitely say that DOACs, I believe, are safe and effective, and I don't view P-Vera and JAK2 such as we would like antiphospholipid antibody syndrome, where you really need a DOAC. So I have many of my patients are on DOACs and they've been doing well. And as I said, there hasn't really, there has been a few cross-sectional studies or real-world studies showing that DOACs are safe and effective. Now, DOAC with aspirin, I think, again, you really have to consider what you're doing with aspirin in P-Vera. If they need to be on a DOAC and say they also have coronary disease and need an antiplatelet agent, well, then we accept that heightened risk and we sort of work with our cardiology friends. But I think purely just aspirin as a prophylactic primary prevention when you're on a DOAC, I think that's maybe a little not needed. Probably not very effective and potentially, of course, more risky.
Yeah, Dr. Pujita, go ahead.
Good evening, sir. Good evening, ma'am, for such an excellent talk. Part of my questions were already asked by Dr. Kripa. I just wanted to know from my Indian colleagues, does any one of you are monitoring the VAF as mentioned in the webinar, sir?
Not really. I don't think it's the standard of care at the moment in India.
Okay, sir. Thank you. Just that.
And it is also not widely available in clinical practice.
And I think these are our challenges. As I said, I've been very lucky because I did it for years as a research in my research laboratory. I had and so I gained this sort of knowledge and understanding. And now we also have it clinically. There was a question. Oh, sorry. Yeah.
Yeah, that's it. Thank you. Thank you.
Okay, Pujita, thank you. Once again, before we go to Dinesh, there's a question in the chat box about stopping the anticoagulants once you have put somebody on anticoagulants for a thrombosis. Yeah,
and I think it's a risk-benefit ratio. And someone I think wrote in the chat again, what about in patients? So for instance, I have a patient I met probably 15 years ago, and she presented with a splanchnic vein thrombosis with normal CBC, and she's always through all this whole time has had normal blood counts, but she does have JAK2 positivity, and her allele burden is around 20%, and it's been this way all this time. She's been on warfarin anticoagulation. I've tried to get her to switch to a DOAC, but she's a wonderful person and she feels comfortable on warfarin. But I really wonder, like, would I ever, and her, she actually presented with Budd-Chiari. She had a TIPS and reopened. She does not need to go on to liver transplant as far as we can tell you. She's really done very, very well. But this is a great question. Would we ever discontinue her anticoagulation? She still has this risk factor. And so I view her as someone like antiphospholipid antibody syndrome, or maybe not that severe, but she has she's had a prior event and her risk factor is still there with her VAF. Now in the setting of driving down the VAF with an interferon, would you then stop your anticoagulation? Great question.
Thank you. Dr. Dinesh, your question.
Good evening. Thank you, Dr. Ellison, for the wonderful talk. My question is regarding the microvascular disturbances, which are common in the MPN. So how will the management of these patients different from macrovascular thrombosis?
Yeah, so I didn't quite catch microvascular versus larger vessel, right? Macrovascular. So the microvascular ischemia, you mean, such as erythromyalgia? Is that what we're?
Dinesh?
Yeah. Headache or erythromelalgia or TIA, which are common in MPN patients.
Yeah, exactly. So, and again, I think it depends which MPN we're talking about. I think for sure, if you're having erythromyalgia, an antiplatelet agent is extremely useful. And that is the one circumstance where, wow, you can get so much clinical benefit with just a little bit of aspirin. or even a little bit more of aspirin, depending on the patient. So for sure there. Now, when my patients are having a lot of erythromelalgia and they have a platelet count of 1 million or 800,000, and again, if, I'm not so enthusiastic about hydroxyurea in the ET setting, I will try to use an interferon to drive the JAK2 burden down. There is not an association with erythromelalgia and macrovascular thrombosis necessarily, but we always worry about that. And now knowing what we know, well, if they have JAK2, you really need to worry that they are at higher risk. The second part of the question, certainly TIA, very concerning. And there again, I would be very pressed to try to not only use an antiplatelet agent, maximize their cardiovascular risk, disease modification, but also really try to use disease modifying therapy, such as ruxolitinib if it's polycythemia vera or interferon, or if it's an ET setting, to use an interferon as your primary therapy.
Thank you.
Thank you, Dinesh. Again, before we go to Gopinathan, a question from the chat box. Does VAF predict development of myelofibrosis and leukemic transformation?
Yes, thank you. So within PV, absolutely. I showed a couple of this cross-sectional studies, and even I didn't get into the details about the more recent studies. So there's a wonderful study called MAGIC PV. This is done in England, Britain, and it's a multi-center study where they're looking at prospective ruxolitinib versus I think best available therapy, but not in failed. Again, it was just randomized to, okay, we're going to treat these patients. And again, how much VAF at present and VAF reduction correlated with, in the ruxolitinib arm, correlated with stem cell reduction and extramedullary hematopoiesis improvement. So yes, VAF over 50%, especially if it's someone who's just recently diagnosed, like they're already, or you meet people who are at 60% VAF and they came in, with new PVERA. This is someone that, yes, they have a very high risk of progressing to myelofibrosis in the next 10, I know we laugh in PV, in the next 10 years, but 10 years goes quickly. You all will find that, right? It does go quickly. So yes, now in AML, it's not as clear. Certainly if you proceed to a myelofibrosis phase with PVERA, and VAF will be high, and your AML risk, because you're in a myelofibrosis phase, is also higher. So that's a little bit confounded by that you've gotten to myelofibrosis phase, and that seems to, it's been my experience that people with high VAFs tend to also have additional mutations, such as ASXL1 or other clonal hematopoiesis lesions that are more high risk to push them along to higher grade disease.
Right. Next question from Dr. Gopinathan is another brilliant fellow, gold medalist all through. Yes, Gopinathan.
Good evening, sir. Thanks for always the nice introduction that you gave to me. And thanks for the very nice lecture, ma'am. I had a lot of new insights, a lot of new learnings today. One query is, ma'am, I have recently come across 2 patients with central retinal vein thrombosis. So their autoimmune workup, everything, autoimmune workup, anticoagulation workup, everything has come negative. So how common is this MPN in association with CRVO?
Yeah, that is not one that came up in our meta-analysis or in my clinical experience. And we just all cringe, right? Because that is such a difficult entity, the central retinal vein thrombosis. So it does not speak to me. Now, I always would get a JAK2 VAF because it is really hard to know. You don't, and so it's worthwhile as part of the hypercoagulable workup to do it. But again, it's not a highly prevalent lesion in that context.
Thank you, ma'am.
Thank you, Dr. Gopinathan. Before we go to Dr. Sanjukta, one more question. Splanchnic vein thrombosis with the JAK positivity and blood counts normal.
Yeah.
What is the risk of developing myelofibrosis? And would that be aborted by using ruxolitinib or interferon?
Yeah. Thank you so much. And that is, I have a whole clinic of these patients also, right? Because we meet them in the hospital, and very puzzling as to why they did this and have normal counts. Again, I would say I have a number of patients. The patient I just discussed, who's been on anticoagulation, who got TIPS. Now, she has not progressed to myelofibrosis low these many years, but she also has a low VAF. So I think, again, every patient's a little different. You know, I think it's hard to say where they're going to go, but I think using VAF can help guide us. So if they really are at a low VAF and they've had this event and they have normal counts, you know, we use anticoagulation and hope for the best. But if we start to see VAF rising, then I think this would be either ruxolitinib if they're really symptomatic, but in this case also if they're not symptomatic and they don't have a spleen to go after in terms of extramedullary disease, this might be someone that I would consider an interferon to try to reduce that burden and hopefully prevent that risk of it rising and developing. I think all of us have had so much experience. I've met individuals in my clinic who got referred to me by a liver transplant doctor, and they had their Budd-Chiari event 15 years before. They had normal counts. And again, I see them, I get a JAK2, it's positive. And, you know, this has been going on for so long, they haven't really progressed. One individual, I just remember, I met him in his 60s, he's a wonderful music teacher. He had this event, they told him he was an alcoholic, you know, and he would need a liver transplant. And of course, he's done fine all this time. But at the end of our 45-minute consultation, when I was explaining that he had JAK2 and he acquired this, you know, he said, is that anything related to my high platelet count that I had in my 20s? He was in his 60s, you know, when I met with him. So again, so many decades ago, he had evidence of an MPN. But I think this latency is something that we really have to recognize, that it's been there a long time. It's been a risk factor. For some reason on day X, it's like a car accident. You drive every day and you don't get in an accident. And when everything comes together, it's there. But once it's there, it's now a definite risk. Okay, sorry.
Yeah. Dr. Sanjukta, your question.
Good morning, Dr. Moliterno. Thank you. That was a fabulous presentation. And I know your whole presentation has been about JAK2 positivity. My question is, you have a patient with polycythemia or erythrocytosis with a low erythropoietin level. JAK2, exon 12 and 14 are negative. What would you put their thrombotic risk at? And would you recommend to keep their hematocrits at the level that you recommend for patients with polycythemia? Would you intervene to get their hematocrits under that level?
Oh, thank you for that question, Dr. Rao. That is the ultimate, and I think we all have this question in a few of these patients. So I would say that I have a number of patients in my clinic like this, and I don't know what to call them. I will, if I can't say I really have patients that I believe have P. vera that do not have a JAK2 lesion demonstrable. You know, it's a little frustrating because we don't have, so if your patient doesn't have thrombocytosis or leukocytosis, you know, what do they have? Do we really call them P. vera? it becomes now is PVERA really defined by JAK2 mutation positivity, right? Is that a subset? So I always get nervous when people are calling someone JAK2 positive, and myself included, who don't have a JAK2 mutation. In my last few years, I've had opportunity for some of these patients to send for whole genome sequencing, and have discovered a few HIF lesions. So, hypoxia inducible factor in that pathway. And they do tend to have higher EPO levels, like EPO levels of 30 to 50, so they are different than the patient you're talking about. But some of them have been told they've had PVERA and they've been phlebotomized for years as a PVERA, and they absolutely don't have that. I think it's a real question in erythrocytosis alone. And I know in a low EPO state, you worry that this really is an MPN. But I think there are more and more data that suggests that phlebotomizing to a PVERA target when you don't have a JAK2 mutation and you don't really have evidence of an MPN is not preventing anything. So I take an individualized approach with my patients. I have a young woman who actually I'm really puzzled. We've bone marrowed her a couple of times. She does have a high hemoglobin, but her white cells and red cells have been normal. She got very symptomatic with phlebotomy and iron deficiency. And so it's hard to know what she has, but I think her thrombotic risk in general is low. So I'm not holding her to that. But I think that's a really great question. I think we really do have to question whether you really think the patient has an MPN. And I think now that we have such sensitive JAK2 testing and exon 12 testing, I think you can hold on to that as really the thrombotic risk is tied to that, and not so much due to high erythrocytosis from other causes.
Thank you.
Hope that's helpful.
Yeah, absolutely.
Thank you, Dr. Sanjukta. Again, before going to Satish, another question from the chat box is there any advantage of doing JAK2 allele burden studies from the bone marrow?
Oh, that's a great question. And there's been a few now that really look at, they're very similar. Peripheral blood, which of course is much easier and nicer. And often, patients already had a bone marrow somewhere else. You don't really want to repeat that just to get a JAK2. It's just as valid to get off of the peripheral blood. So, yeah.
And another question is the natural history of exon 12 versus exon 14 different?
Yes, there have been signals, and in our cohort, we've looked at that. They tend to have more of an erythrocytosis alone phenotype, but again, their allele burden probably is as meaningful as the JAK2 V617F allele burden. So I have seen patients with exon 12 lesions that have, in our NGS panel, they'll be quantitative, and if they also get uniparental disomy or that mitotic recombination, so they tend to get homozygosity and high allele burdens. So again, I think allele burden can direct you. But yeah, I have seen some who develop the full-blown, splenomegaly and myelofibrosis phenotype.
Thank you. Satish, your question.
Thank you, sir. Thank you, Dr. Allison, for that mind-boggling and eye-opening concepts. I really like the slide where you said the higher the allele burden, it progresses from ET to PV, because I have a couple of patients, one young lady whom I diagnosed JAK2 positive MPN, probably essential thrombocythemia, because she had only high platelets, her PCV was bang normal. And over the years, I think next 4 or 5 years, the PCV started increasing. And now her WBC count is almost 30 to 34,000. Now I understand that probably her allele burden is gradually increasing. She has a spleen palpable around 15 centimeters on the imaging, LDH is high, and whatever you said, everything was fitting into her. So in such patients, as you said, Ropeg would be the best choice for her because she's quite young. She's in her 30s or early 40s. But in India, Ropeg is not available. Unfortunately, it's not available. Can we use the usual pegylated interferon alpha 2B?
Absolutely, and and I've had about 20 patients on Pegasus, and I have switched some to Ropeg. But I've had, and actually, if you look at some of the Danish studies where they've been studying interferon, the allele burden reductions, when they happen with PEG, seem to be on the same vein as ROPEG. So I think it's quite good. I would wonder in a patient like this, I don't know how, and I have many patients like this also, very, very young, and when they progress like this, I worry that ROPEG or that Pegasus may not bring them, get their disease under control. This is someone, I don't know if she's tried ruxolitinib, if you have that available, but that might be either a trial of that for a couple of years and then move over to an interferon for kind of more, hopefully long-term therapy.
Yeah, that brings me to the second question, ma'am. Which cases do you prefer ruxolitinib over ROPEG or PEG interferon?
I now for very symptomatic patients. So we all have had patients who itch like mad, or who progress like this, have progressed quickly with a big spleen. I will actually use ruxolitinib first to try to get disease under control, to try to make them feel a little better, right? And then hopefully move over.
PEG interferon.
Yeah. Mm-hmm.
And the other question was regarding the treatment. Once we start DOACs, after 6 months, because of the recent trials extended phase where we can reduce the dose to a preventive dose, like if they're in rivaroxaban 20 mg, can we cut down to 10 mg or the preventive dose in MPN with thrombosis?
That's such a good question. And I think it's really how you scale the risk factor. If their event was like my patient who, the patient I presented, he had a pulmonary embolism after prostate surgery. And then he broke his ankle hiking in France and got a DVT. After, right. So I actually did put him on a DOAC after the DVT. That's when I met him. And now a few years later, we have gone to a prophylactic dose because I felt, well, gee, in his circumstance, he certainly has a risk factor, but they were provoked. Now people could argue with me, right? And that's why, we have these conversations every day. I think in the setting of splanchnic vein thrombosis, it's very tough to ever back off, right? Because the risk is just, who knows if it's going to happen again, right? But it's such a devastating circumstance that that's someone I wouldn't go. But for especially DVT or PE that may have had a provoked component, their disease was outed, like my patient by doing the hyperquide workup. Another question people always ask me is, do we always use JAK2 V617F in the hypercoagulable workup? And I think this is a context question for all of us. I think if certain splanchnic veins, cerebral vein thrombosis, those are, of course, do it. But for straight up DVT or PE, probably not as good a yield unless there's a CBC abnormality, like a increase in platelet count. So.
What about arterial thrombosis, ma'am? Like young stroke, young heart, young MI? Without any other risk factors.
Yeah, I think it's always worthwhile to do, and again, it's not so expensive. And if there's any hint, right, that their CBC over the past 10 years, as you know, right, has been abnormal, it's certainly
worthwhile.
Yeah.
Thank you so much, Dr. Ellison. Thank you. Thank you.
Thank you, Satish. Another question from the chat box. You have publication on this PAYA, young patients. So somebody has come with the very young patient, 4-year-old, essential thrombocythemia, JAK2 positive. What's your management? 4 years old with JAK2 positive thrombocythemia, essential.
Yes, I think in our PAYA publication, the youngest individual we diagnosed with JAK2, I believe, was a 9-year-old. This is described, though, in younger, and even in utero, there's a idea that the mutation occurred. A patient was in utero. A really great question. And I would might ask you to defer to my colleague, Nicole Cuisine, Kucine. She's at Cornell in New York City, and she's really been the leader of pediatric and true pediatric MPN. I think that's a real risk-benefit issue for this child in that, what's the risk of taking, say, an interferon? Certainly hydroxyurea, no, right, over the lifetime of this patient. But, do you need a disease-modifying therapy? I can't recall, did this patient have a thrombotic event or just found to be positive?
Not mentioned, and it's in the chat box. There's no way to contact.
Yeah. So, I think it really depends on if they've had any thrombotic events. In many of these patients, we will just monitor, and we have concerns that they're probably very at high risk of developing PV. If they move into a PV phase, I think an interferon would be very useful there, as opposed to phlebotomy. So yeah, but anyway, Nicole Cuisine, Kucine, and she's really been collecting probably the largest number of kids, and she's very approachable.
When we are on this subject, you want to comment something about the familial MPN?
Yes, so thank you so much. And we've published a little bit about that too. And in our cohort here, and it's been described now for decades, about 10% of individuals with an MPN, but let's just talk within PV, will have a first or second degree relative also with MPN. So like, why is that? There's certainly, we know that there's a JAK2 haplotype that seems to confer a statistical increased risk of acquiring the JAK2 mutation. The MPN risk is not always the same flavor. So I have patients who are JAK2 positive, but their father was diagnosed after, and they have CALR mutation positive myelofibrosis. So this familial, like it's not purely always the same MPN. So I think when we look at that, and what I've noticed, it doesn't seem to worsen your prognosis, having a family history. I think the risk factors for clonal hematopoiesis, so why we get clonal hematopoiesis in populations, overlay the same risks of why we get some familial predominance. So it's like an accumulation of many genomic factors that increase this risk. The JAK2 mutation is one of the most common errors in our bone marrow stem cells. And we don't like to think about our own bone marrow stem cells and what's going on there. But, if you could look at all of mine, I bet you would find a JAK2 mutant cell. It's a very common typing error, I always tell my patients. So it's happening with us all. And so there are many factors of why in a family it might happen more or allowed to expand enough to become a disease. So I think we have to look at it in those levels of, well, what's the risk for clonal hematopoiesis in general? What are those risk factors in us? And certainly many germline risks. We did publish a paper about variations in ATM, and we also have a family that has an ERBB2. So certain cancer genes, cancer predisposition genes, I think are probably MPN predisposition genes. In those families, they not only had MPN, they had other solid tumors that co-segregated. So, and more recently, POT1, which is a gene that protects telomerases, and POT1 variants have been described as predisposition for CLL, but also clonal hematopoiesis and JAK2 positive MPN. And Mary Armanios, who studies telomeres here, she just published a beautiful paper in the New England Journal about POT1 families, and actually there was quite a bit of JAK2 in those families of carriers of POT1. So again, many different genomic or pathways can lead to increased risk.
Thank you. Another question is, once a patient has developed secondary acute myeloid leukemia, is there any role of continuing ruxolitinib and interferon, or they can be stopped?
Yeah, I think there's probably not a great role for interferon at that point. Very difficult situation.
You have also published about higher incidence of developing pH positive CML in patients of.
Yeah. That also came out of our cohort, and a surprising feature. And again, what is that? But yes, we had been following about 630 individuals in this cohort, and they all came in at different times in their disease, but we presented these, I think 6 that came out over the time period who developed CML after having developed JAK2. Most of them were JAK2 positive. A couple were CALR, but many years. So it wasn't like they had CML and PV or their other MPN. This came out of a long-standing MPN. I know one of those patients has a sister also with JAK2 positive ET. So you wonder again, is this familial predisposition also allowing other mutants to occur? But most have done well with treating the CML, getting that under control, and then going back to chronic phase of their other MPN. So it's quite challenging,
And one last comment about this effect of gender, males doing worse than the females.
Yeah. I for a long time, and again, if you look at the breakdowns of like just within a single mutation like JAK2 positivity, if you take 100 women who have gotten JAK2 and 100 men who have gotten JAK2, the women will segregate to ET and PV phenotypes, whereas the males will segregate to PV and MF phenotypes. And so many other people have shown this, but and that's also true if you just look at CALR mutation positive, or a MIPL is so rare that I don't think we have enough patients really to look at. So while women may acquire have a lot of ET, right? So women may get JAK2 more, but again, what they do with it, how JAK2 is sort of processed through a woman's genome versus a man's seems to be very different. And we know that males tend to have acquire more high-risk additional mutations to in spliceosome factors. So again, they sort of tilt more towards a more higher grade.
One more last question. Would you do NGS panel for all the patients of polycythemia vera?
Such a great question. I'm always interested in information for my patients. And I think, NGS is, well, it's expensive, and, really you look at 100 PV patients and what is the NGS really going to tell you? Well, one, it's a way to get a quantitative JAK2, which is very nice, right? So that's one great thing about the NGS panels. They will give you the quantitative JAK2, so you don't have to order it separately. I think in a patient who is progressing quickly or presents is young and has a high white cell count of 38,000 that we just discussed, that would be very nice to know if they have ASXL1 or other high-risk lesions in addition to their VAF. So I think for most patients, I wouldn't do that as but it almost gets to the point where, well, would you prefer to do a bone marrow and spend the $1,000 that it costs to right, get these studies and right, just for morphology, or would you rather put our dollars towards an NGS? Bone marrow, you get a karyotype, very unusual for that to be informative in a newly diagnosed PVR patient. And even the bone marrow morphology. I mean, yes, it's nice to know if you've got evidence of fibrosis, if you're newly diagnosed with PV, but your high JAK2 might tell you that, or might get you to be concerned about that. So I think these are questions that are very, very important. I think in my practice, often the NGS is done when already by the patient comes to me. For our MPN workup at Hopkins, we have JAK2, CALR, and MPL all on our NGS panel. So it's almost as cost efficient to get an NGS, particularly if you're working up ET, right? So you don't have to do JAK2 and then CALR and then MPL. So in certain circumstances, it seems to be cost effective.
Like one last.
No pathologists in the audience. I didn't want to offend pathologists.
No, there must be, so many people.
There must be.
Pathologists. Always.
I love pathologists.
Yeah, okay. Do you ever do transplant in a case of polycythemia vera short of myelofibrosis?
Oh, I advocate for it, particularly in patients who are young. And what is young? But, below 70, who have high allele burden and have failed disease-modifying therapy, right? So I have a lot of patients where we started with phlebotomy alone, and then we tried interferon for several years, and disease kind of progressed. Then we went to ruxolitinib, and they got good disease control, but then again started losing response. That's the kind of patient I would advocate for a transplant. We have to look at our patients, right? And especially very nervous about our patients in their 20s and 30s. We can say, oh, the first 20 years are going to be great, and they will be. But that only takes them to 50 or, and nowadays, 50 is still pretty young. And again, I think we are expecting that we have longer survival. So I do advocate for it. I have taken a few patients through and have done well. So, it is quite a thing, right? The first couple of years of that recovery and setbacks, but I do. And so we factor age and certainly how they've responded so far. I think it is a real question now. I do have some patients who have been on Pegasus or now Bezremi, and they have allele burdens of less than 5%. And, they're 45. And hopefully this will continue, but it is a real question.
Thank you, Dr. Ellison. I think that was the last question. You have helped us tremendously, gave a very different angle to the subject, and educated us beautifully. I think this will help the patient care to all those who have listened to you today. And I really have no words to express my gratitude. You gave a beautiful talk, and then this question and answer session was fantastic. Almost about 2 hours you have been with us.
Oh, thank you so much. And I appreciate everyone. Saturday night, this is an amazing group of hematologists and group, and I'm just so honored and thrilled. I just can't believe this. It's really wonderful.
This is it.
And I hope you invite my other colleagues from Hopkins to do this for you. It's really wonderful. So thank you so much. And I just have to say, the conversations that we've had today about our patients and all these wonderful doctors. First of all, I hope we can meet each other at ASH sometimes if you go to ASH. And these are the exact conversations we have on our Wednesday coagulation rounds with our group. So I feel like we're just all together puzzling over the same circumstances and questions. So I appreciate your expertise, all of you. Thank you.
Thank you so much. This is a recreation for us. Saturday evening. And,
You guys are hardcore. All right. Well, I hope you have a good dinner.
bye-bye. Have a wonderful day. And thanks to all our colleagues. And thanks
Thank
to
you.
event management team. And thanks to Novartis for supporting. Bye-bye. Bye.
Bye-bye. Bye, everybody.